Good morning, everyone. Myself, Patel Priyanka, nursing tutor from Knowledge Institute of Nursing. Today, we are going to learn about respiratory system. So, starting with that, in that we will see how to perform respiratory assessment, how to collect history for that. So, to begin with that, if we see the introduction of a respiratory assessment, that is the primary purpose of a respiratory system is that is a gas exchange, which involves a transfer of oxygen and carbon dioxide between the atmosphere and the blood. The respiratory system is divided into two parts, that is upper respiratory system and the lower respiratory tract. The assessment of a respiratory system, as body grows, lung will be also enlarged or it will be expand, and likewise even there will be some fluctuation in a respiratory rhythms. So it will be different in both, like it will respiratory pattern will be different in baby and adult one. So accordingly we need to find out, we need to perform the respiratory assessment. Nurses who care for the client experiencing respiratory disorder perform and interpret a variety of assessment procedure. Diagnostic procedure also have make use the plan of a care for a client with the respiratory problems. First, but if we see the history collection is a initial stage to perform respiratory assessment. Not only a respiratory assessment, but it is the initial step to plan for any kind of disease. So, if we see the history, we need to talk to the patient, and if patient is not able to speak anything, we can take some information from their relative also, relative or his or her friend. So we need to collect the history. First and foremost, it will be the personal data, like personal information, name, age, and all that things. And after that, if we see the systematic history, in that we will, if it is a respiratory system assessment, so we need to take history regarding any problems related with the respiratory system. So first and foremost will be, we will ask about the dyspnea, that is a difficulty in breathing or a breathing difficulty, we can say. So in that we need to ask a patient, is the dyspnea is acute or chronic one. If they are having respiratory problem or a difficulty in breathing, it is a sudden or it is a chronic, or if they are having any kind of previous history of any medical histories regarding which is related to the respiratory system, or if they have underwent any surgeries for a disease treatment. Has it come about suddenly or gradually? Is more than one pillow required to sleep? If person is requiring one or more than one pillow, it is indicated, like if anybody is having breathing difficulty, he will be in a head up position. Is the dyspnea progressive or recurrent or paroxysmal? Walking, how far leads to the shortness of breath? And not only walking, or we can say body, if they are lifting any kind of weight or any physical activity, how far lead to the shortness of a breath. So we need to collect all this history about the dyspnea, and we can if we see the associated factors which are related with the dyspnea, so it will be, is there a cough associated with the dyspnea, and it is it productive? So we need to take history regarding cough also. What activities precipitate the shortness of breath, like if they are running or they are around the dust, any that kind of any activity which are triggering the shortness of breath. So we need to take history regarding that also. Does it seem to be a worse when it is upset, if they are in a stress kind of situation? Is it influenced by the time of a day, season, or certain environments, like in a cold season? So we can even plan treatment accordingly. Does it occur at a rest or a exertion, sorry, does it occur at a rest or a exertion? Any fever, chills, night sweat, along with that dyspnea, any changes in a body weight? So we need to take history for this too. They are like we need to perform all the physical examination step. Is there a patient history or a family history of a chronic lung disease, cardiac, or a neuromuscular disease? If they are having any kind of past history or a past surgical or medical history, if they are having any kind of bad habit like smoking, and if they are having smoking bad habit, so we can take history like how from uh, when they have started smoking, or how long they used to smoke. So we can take history. And significance, if we see, the sudden dyspnea could indicate the pulmonary embolus, pneumothorax, myocardial infarction, acute ventricular failure, or a acute respiratory failure. In post-surgical or a postpartum patient, dyspnea may be indicated pulmonary embolus or a edema. Orthopnea can be indicative of a heart disease or a COPD. COPD stands for a chronic obstructive pulmonary disease. If dyspnea is associated with the wheeze or a wheezing sound, consider asthma, COPD, or a heart failure. Now about the chest pain. So if we see the characteristic for a chest pain, is the pain sharp, dull, or a stabbing or etching? Is the intermittent or persistent? Is the pain localized, or it is radiated, like it is radiating towards other part of the body? If it is radiate, where they are radiating this pain? How intense the pain? There are factors that elevate or aggravate the pain, such as a position or activity. Like if any person in a spine position or a sitting position, in that specific body position only, or a body posture, they are having pain. So we need to take history regarding that also. Associated factors, like what effect do inspiration and expiration have on the pain while they are having pain? So what will be the inspiration and expiration pattern? What the other symptoms accompany the chest pain? There are, if there is diaphoresis, which means excessive sweating, shortness of breath, or a nausea, if person is having, along with this dyspnea or a chest pain, if they are having this kind of problem. So history will be like, is there a smoking history or a environmental exposure through which they are suffering from all these kind of symptoms? Has the pain ever been experienced before? Like if they are previously also they are affecting with all these things. What was the cause? And if they are experienced with all these things, what was the cause for this? Is there a pre-existing pulmonary or a cardiac diagnosis? We need to take history regarding that also. If we see the significance, chest pain related to the pulmonary causes the usually felt on the side where the pathology arises, but it can be referred. Dull persistent pain may indicate carcinoma of the lung, whereas the sharp or a stabbing pain usually arises from a pleura. Cough. The next is a cough. So characteristic or a history we can say, like we what history we need to take. So is the cough dry, hacking, wheezy, or a more likely to clear the throat? Is it strong or weak? How frequent it is? Is it worse at night or at any time of the day? Is it aggravated by a food intake or excretion? Is it elevated by any medications? How long it has been going on? So we need to take history regarding this also. Associated factors we can ask them ask the patient about like is the cough productive? If so, what is the consistency, amount, color, order of a sputum? Because by this also we can get so many of the details or a data. Like if there is a blood presence, hemoptysis will be there. Is associated with the shortness of a breath or a pain. So we can take history regarding that also. History uh, has there been any environmental or occupational exposure to dust, fumes, or gas that could be lead to the cough? We can ask the patient about this also. Is there smoking history? Is the smoking current or in a past? Even if we can ask to the patient if they are continuously being a passive smoker. Passive smoking is like if somebody is smoking and we are nearby them, so that smoke will be inhaled by us also. So we need to ask the patient about that history also. Are the past pulmonary diagnosis asthma, rhinitis, allergy, or exposure to allergens such as a pollen, house dust mite, animal dander, mold, cockroach waste, irritants like smoke, or any specific odors like strong odors, perfumes, cleaning products, exhaust, pollution, or a cold air. So we can take history. If we see the significance for this, a dry, irritative cough may indicate the viral respiratory tract infection. A cough at a night should alert to a potential left-sided heart failure or a asthma at a night if it is at night. A morning cough with a sputum might suggested for a bronchitis. Severe or a changing cough should be evaluated for a bronchogenic carcinoma. So it suggests that there may be a carcinoma. Consider bacterial pneumonia if sputum is rusty and the lung tumor is pink tingled. Profuse pink for this sputum could be the indicative for a pulmonary edema. A cough associated with the food intake could be the indicated problems with aspiration.